There are 4 components of care. The first one is assessment and monitoring. Assess asthma severity to initiate therapy. Assess asthma control to monitor and adjust therapy. And schedule follow-up care. Use severity classifications to assess both domains of impairment and risk for initial treatment. Use the asthma control chart to assess impairment and risk to determine if therapy should be maintained or adjusted, if the therapy needs to be stepped up, or if the therapy should be stepped down if possible. Use multiple measures of impairment and risk to different measures assess different manifestation of asthma. They may not correlate with each other, and they may respond differently to the therapy. Obtain lung function measurements by spirometry at least once every 1 to 2 years. For more frequent for asthma that is not well controlled, asthma is highly variable over time, and periodic monitoring is essential. In general, consider scheduling patients 2 to 6 weeks intervals while gaining control of asthma, and 1 to 6 month intervals, depending on steps of care required or the duration of control to monitor if it's sufficient control is maintained. 3-month intervals if a step down in therapy is anticipated. Asthma control medication techniques, written asthma action plans, and patient adherence and concerns should be addressed at every visit. The next component is education. Provide self-management education. Develop a written asthma action plan in partnership with the patient. Integrate education into all points of care where health professionals interact with the patient. It is important to teach and reinforce self-monitoring to assess levels of asthma control and signs of worsening asthma, either symptoms or a peak flow meter can show similar benefits for most patients. A peak flow monitoring may be particularly helpful for patients who have difficulty perceiving symptoms or have a history of severe exacerbations. Use a written asthma action plan. Review the differences with your patients between long-term control and quick relief medications. Take medications correctly. Teach your patients the proper techniques, how to use their inhalers and other devices. Maybe like this, a holding chamber for their inhaler. Avoid environmental factors that could worsen asthma. Tailor education to the literacy of your patient. Appreciate the potential role of a patient's culture, beliefs, practices, and asthma management that could affect how they manage their asthma. Agree on treatment goals and address patients' concerns. Provide instructions, daily monitoring, managing of worsening asthma. Involve all members of the healthcare team in providing reinforcement education, including physicians, nurses, pharmacists, respiratory therapists, and asthma educators. Encourage education at all points of clinical care. Clinics offer self-management education programs as well as incorporate education into every patient's visit. Emergency departments and hospital, pharmacies, and schools, other community settings, and patients' homes. Use variety of educational strategies and methods. The third component is control environmental factors and comorbid conditions. Recommend measures to control exposures to allergens and pollutants or irritants that make asthma worse. Treat comorbid conditions. Determine exposure histories of symptoms and presence of exposures and sensitivities. Advise patients on ways to reduce exposures to allergens, pollutants, or irritants, which the patient is sensitive to. Multifaceted approach are beneficial. Single steps alone generally are ineffective. Advise the patient and pregnant women to avoid exposure to tobacco smoke. Consider allergen immunotherapy by specially trained personnel for patients who have persistent asthma, and when there is clear evidence of a relationship between symptoms and exposure to an allergen. Consider especially allergic bronchopulmonary aspergillus, gastroesophageal reflux, obesity, obstructive sleep apnea, rhinitis and sinusitis, stress, depression, recognition and treatment of these conditions may improve asthma control. Consider inactive influenza vaccine for all patients over the age of 6 months. The fourth component is medication. Select medication and delivery devices to meet the patient's need and circumstances. Use the stepwise approach to identify appropriate treatment options. Inhaled corticosteroids are the most effective long-term control therapy. When choosing among treatment options, consider domain of relevance to the patient's impairment, risks, or both. Patient history of response to the medications, patient's willingness and ability to use the medication. Stepwise approach goals. The stepwise approach incorporates all 4 components that we just covered of care: assessment of severity to initial therapy, or assessment of control to monitoring and adjusting the therapy, patient's education, environmental control measure, and management of comorbid conditions at every step, and selection of medication. The type, amount, and scheduling of medications is determined by the level of asthma severity or asthma control. Therapy is increased, which is called a step up, as necessary, and decreased, which is called a step down when possible. Because asthma is a chronic inflammatory disorder, persistent asthma is most effectively controlled with daily, long-term controlled medication directed towards suppressing inflammation. Inhaled corticosteroids are the most consistently effective anti-inflammatory therapy for all age groups at all steps of care for persistent asthma. Selection among alternative treatment options is based on consideration of treatment effectiveness for the domain of particular relevance to the patient's impairment, risk, or both, like we already said, the individual patient's history. Where I covered that, I'm sorry, excuse me. Once asthma is controlled, is achieved, monitoring and follow-ups are essential because asthma often varies over time. A step up in therapy may be needed, or a step down may be needed when possible, to identify the minimum medication necessary to maintain control. General principles for a stepwise approach. All age groups incorporate the 4 components. Okay. The age groups ranges are, we're going to start with 0 to 4. Consider daily long-term control therapy, young children may be at high risk for severe exacerbations, yet have the low levels of impairment between exacerbations. Initial daily long-term control therapy for children who have had equal to or greater than 4 episodes of wheezing in the past year that lasted greater than 1 day and affected sleep, and who have a positive asthma risk profile. Either one of the following: parental history of asthma, physician diagnosis of atopic dermatitis, or evidence of sensation to aerologens, or 2 of the following sensations to foods, or greater than or equal to 4% blood eosinophilia, or wheezing apart from colds. Consider initiating daily long-term control therapy. Children who have consistently required short-acting beta-2 agonists treatment greater than 2 days per week for greater than 4 weeks. Children who have 2 exacerbations requiring oral or systemic corticosteroids within the 6 months. Monitor response closely and adjust treatment if no clear and positive response occurs within 4 to 6 weeks, and the patient's caregiver, medication technique, and adherence are satisfactory. Stop treatment and consider alternative therapies for diagnosis if clear benefit is sustained for at least 3 months. Consider step down to evaluate the continued need for daily therapy. Children this age have high rates of spontaneous readmissions of symptoms. The age group 5 to 11 years old involved child in developing a written asthma action plan, address the child's concerns, preferences, and school schedules in selecting treatment. Encourage students to take a copy of their written asthma action plan to school or after school activities. Promote physical activities and treat exercise-induced bronchospasm. Step up in daily therapy if the child has poor endurance or symptoms during normal play activity. Monitor for disease progression and loss of lung growth. Treatment will not alter the underlying prognosis of the disease, but a step up in the therapy may be required to maintain the asthma control. The age group, ages 12 and older, involve youth in developing, writing an action plan, address youth concern preferences, and school schedule and selecting a treatment. Encourage students to take a copy of their action plan with them to school or into after school activities. Promote physical activities and exercise. Treat exercise-induced bronchospasms. Step up daily therapy if child has poor endurance or symptoms, just like before in the other group. Older patients establish reversibility with a short course of oral systemic corticosteroid. Adjust medication to address coexisting medical conditions common among older patients. Consider, for example, calcium and vitamin D supplements for patients who take inhaled corticosteroids and have risk factors of osteoporosis, increased sensitivity to side effects of bronchodilators with increasing age, increased drug interaction with theophylline medication for arthritis, hypertension, or glaucoma. Beta blockers may exacerbate asthma. Okay, now we're going to talk about exercise-induced bronchospasm. Prevent exercise-induced bronchospasm. Treat stages to prevent exercise-induced bronchospasms. Long-term control therapy. Pre-treatment before exercise with a short acting beta 2 agonists, leukotriene receptors, antagonists, chromalin and netochromil. Frequent or chronic use of long-acting beta 2 agonists for pre-treatment is discouraged, as it may disguise poorly controlled persistent asthma. Warm-up periods or a mask or scarf over the mouth for cold-induced exercise-induced bronchospasm. Pregnancies. Maintain asthma control throughout pregnancy. Monitor asthma control during all prenatal visits. Asthma worsens in 1/3 of women during pregnancy and improves in 1/3. Medications should be adjusted accordingly. It is safer to be treated with asthma medications than to have poorly controlled asthma while pregnant. Maintaining lung function is important to ensure oxygen supply to the fetus. Albuterol is preferred. Inhaled corticosteroid is preferred long-term control medication. Budesonide is preferred because more data are available on this medication during pregnancy. Surgery. Reduce the risk for complications during and after surgery. Assess asthma control prior to surgery if lung function is not well controlled. Provide medications to improve lung function. A short course of oral systemic corticosteroids may be necessary for patients receiving oral corticosteroids during 6 months prior to surgery. And for select patients on high doses of inhaled corticosteroids, give 100 milligrams hydrocortisone every 8 hours intravenously during surgical periods, and reduce the dose rapidly within 24 hours after surgery.